Hey, Plus Sides fam. This week, we're actually reposting an episode from season 3 about GLP-1 medications and the heart. I hit home this week when my friend Dave Knapp from the show On the Pen posted that he was struggling with some heart issues and exhaustion because Dave struggles with type 2 diabetes and obesity. I lost my brother in law a few months ago to a heart attack, and he also struggled with type 2 diabetes and obesity. And I just thought it would be a really good opportunity because we get so many new people all the time that listen to the podcast or watch the podcast to resurface this episode to make sure that we understand that these medications treat diseases and disorders and help with so many dysfunctions. And it's just so much more than weight loss. And I wanted to make sure you heard this from an esteemed cardiologist in this field. And that is what this episode is, as well as my friend Priscilla, who suffered from a heart attack and is on a GLP-1 medication, so that you can hear her brave story and how it all relates. I hope that you enjoy this special bonus episode and that you will take the time to please give us a 5-star review on the audio platforms. And if you're watching this, give us a thumbs up and comment to create engagement for us so that we can get pushed out and help more people know that they are not alone and it is not their fault. Okay, so knowledge is power. I hope that you love this episode. Are you interested in understanding GLP-1 medications like Ozempic, wegovy, or Mounjaro? Then join us on the Plus Sides, Cracking the Obesity Code, the groundbreaking podcast helping people change their lives one episode at a time. The Plus Sides podcast is a disruptor. We're breaking down barriers, smashing stereotypes, and sharing inspiring stories that'll leave you feeling informed and empowered. Join us every week to learn from doctors who are specialists around GLP-1 medications like Ozempic, wegovy, and Mounjaro. They'll provide you with science and facts to validate these incredible stories. But that's not all. We'll also bring you the voices of the GLP-1 Mounjaro TikTok community, real people who face the challenges of obesity-related diseases and disorders and discovered the incredible plus sides of GLP-1 medications. Our episodes are filled with heartwarming stories, laughter, and moments of triumph. You'll connect with our amazing community members who are reclaiming their health and experiencing their fullest lives. Are you ready to embark on a journey of discovery and empowerment? Tune in to the Plus Sides, Cracking the Obesity Code, and together we'll change the narrative around obesity and end the stigma. Subscribe now on YouTube or your favorite podcast platform and join our incredible community. Let's celebrate the plus sides of life together because every story deserves to be heard. Every life deserves to shine, and everyone deserves access to expert knowledge and medication. The Plus Sides Podcast. You're not alone. It's not your fault. Welcome to the Plus Sides Podcast.
Welcome. Yeah.
Anyway, hey, let's get started.
Do this.
So tonight we have Sabrina and Kat with us. So we'll just go around. My name's Kim, for those who are new. This is the Plus Sides Podcast. We focus on education around the diseases of obesity, disorders like PCOS, insulin resistance, etc., type 2 diabetes, and learning different ways to treat that. And that could be with medication, that could be other things to support being on medication, or it could be if you can't, because we've learned a lot of people can't, right? Just different ways to be able to treat your conditions, to understand them, and then be able to advocate for your health. We are an award-winning podcast. This is our 3rd season. We really grew out of a TikTok community. And we've come here to the YouTubery and the Apples and the Spotifys and all the places to spread the GLP-1 gospel. Hallelujah.
Hallelujah. I'm First Lady Sabrina.
And we invite on people from our community to tell their stories, as well as doctors to be able to validate those stories so people can heal and hopefully grow. And we hope that you will stay with us. And that's me. I'm Kim. And what about you? Who are you, Kat? What you doing? Why are you here?
I'm Kat Carter. I am I'm a Libra. Okay, we're not going to go through that again. So I'm Kat Carter. Kat Carter 7 on TikTok. I'm a user of GLP-1 medications and therapies. Definitely here for all the health and science facts and data. And it's really been a joy. It's great work. Lost 70 pounds. I guess, with the addition of Sabrina, we're now the 2 fitties.
Yeah, that's right. And JT and I are soft era. I strength train.
You call yourself a fitty. Do it. Yeah.
No, that's
Fine.
a little harsh. It's a little much. Okay. I do the bare minimum. Okay. And I'm all right with it.
Well, Dr. Ali said, what, 10 minutes 3 times a week is
Yes,
really
I
all
do
you
it
need? Do
I
it.
do it 5 days a week. So,
Do it.
huzzah.
But yeah. So binge eating disorder, recovery, Mounjaro, 70 pounds, all that jazz. It's done a lot of great things for my health as well. And I'm going to keep preaching the gospel because we are Kim's first ladies.
Yes.
Kim is the what, Pastor Kim?
Pastor Kim.
Fear-
Hallelujah.
Fearless leader.
Fearless leader,
But
sure.
she's a GLP-1 evangelist, so we got to
Yes. GLP1 evangelist.
yeah,
That was like my first viral. Hell yeah, it is. Hell yeah,
yeah.
it is. Because it was and still is. It's a disease. So, hey, who are you, Sabrina? What you doing? How you here? What's up?
Hey, hi, Sabrina Ramos. I am on a GLP-1. I've been on Mounjaro since June of 2023. I am down 70 pounds. I was diagnosed with type 2 diabetes and obesity last year. I also, like Kat, love to work out. I am a gym enthusiast. I wouldn't say I'm a gym girly, but I am a gym enthusiast. I do enjoy lifting. My passion is the leg press, but I love it.
But you can tell with your booty, and I compliment you
So,
every time I see.
hashtag doing butt stuff at the gym.
Butt stuff. That's right. Butt stuff with Kat and Sabrina. It should be a whole thing. When you're here, you
Mhm.
guys should go to the gym. Anyway, back to the show. So today we have Priscilla, who we call PMAC, to come on and tell her story, and then a special guest. But we are heavily focused today on how obesity, insulin resistance relates to the heart health and how these medications can help with that. So, without further ado, let us invite on our friend, PMAC.
What's up, P-Mac?
Hi.
So we are so glad to have you here today. I know you know our show and you've been coming to our lives and stuff for a long time. And we're thrilled. I would like to offer you the space to tell your story unfiltered and uncut.
Oh, I appreciate that. Well, first of all, thank you so much for having me. I've watched all of you guys for a long time, and I can't describe the impact that you've made on my life. So thank you so much for that. So I'm going to take you back to the beginning, I guess. There are only 2 times in my life where I can remember not being overweight. First one was being a premature baby at 2 pounds 6 ounces, and the other time was between roughly 2016 and 2018, when I had my lap band surgery success, and I'll explain what success actually is. So I was overweight my entire life, and being an overweight child, I grew up with parents that were both overweight, both type 2 diabetic, and overweight runs in my family. So I was pretty much genetically going to be disposed. I have one sister. She hasn't really had a weight issue her life. However, I learned that through time, she's been white knuckling it this whole time. So I never knew that. But I grew up in an environment where I danced. I did competitive dance. I did dance in school. And I think the first realization that I was not of average weight was probably 6th grade, when we had to go look for leotard and tights, and we could not find any in a size extra large. So back then, the internet wasn't really a thing. So we were having to search high and low to find leotard and tights. And being in competitive dance and having to order costumes every year, that became difficult. And I remember being, let me back up. We had to audition for our competitive dance team, and I was just the same talent-wise as everybody else. Walked up to the sheet that showed all the names of everyone that made it, and I was standing behind a girl, and I vividly remember her going down the list of names of people that made it. She got to my name, looked at her mom, and said, "I cannot believe she made the team. She's too fat." That was the first time that I think I finally realized what was going on. So I then went to a performing arts middle school, did ballet, did modern, and my 8th grade year, my mom was pulled into a parent-teacher conference with my dance teacher to talk about my weight. That was the second time I remember having a conversation about it. And Mama Bear did what Mama Bear does, and she tore into my dance teacher. She was like, "How dare you talk about my child's weight? Clearly she is athletically sound to do everything else that all these other students can do, but how dare you?" Moving into high school, I went to a performing arts high school, and the only way I can describe it is that it's like the movie Fame, but we don't jump up on the tables and dance and sing, but it's like the movie Fame. And from my middle school to my high school, it was a known thing that if you went to that middle school, you were automatically going to go to that high school. You were kind of legacy-ed. And my sister went to the high school too. So it was kind of like, okay, this is kind of a no-brainer. It's going to happen. I got rejected. That was the next time I realized it. And, you know, being in the dance world, weight is very, very important. But that does not mean that you are not talented. I look back then to what I see today, and you just see these people that are dancers, and it's amazing that they're finally being accepted. So I had to re-audition for my high school, and I made it in, performed, did everything just as fine. And then, you know, life goes on. You go to college, and you continue to do what you do. And by the time I got out of high school, I was a size 16. And then went to college, stayed between like size 16, size 18. So in college, I got to about a size 20. And then incrementally, just going into the corporate career, I continued to put weight on. Fast forward to 2006, I started getting migraines. Migraines run in my family, so we didn't really think anything of it. The migraine continued to get worse and worse and worse, to the point where it was affecting me being able to eat. I couldn't keep water down. My vision was getting really, really messed up. And to give you a visual perspective of what was happening to my vision is that I remember trying to drive home one day, and I was in the middle lane. The lanes on this side and this side were physically crossing in front of me. I had double vision. What was happening is my optic nerve was being pushed on and caused this eyeball to go this way. Long story short, I was diagnosed with idiopathic intracranial hypertension, which is with an overproduction of spinal fluid in your body. The best analogy I can give you is that if you think about a toilet and it gets stopped up, your spinal fluid goes up your spine, around your head, and back down your spine. And when your body overproduces too much spinal fluid, it gets backed up. And so the more it gets backed up, the more pressure it puts on your brain. And that pressure was pushing on my optic nerve and caused my eyeball to turn. That condition in of itself is rare. It's about 1 out of every 300,000 people. There's no known cause. There's no known cure. It's just commonly amongst women of childbearing age with a history of menstrual problems. And your temporary relief is spinal taps. So I've had probably about 12 spinal taps in the last 20-ish years. And if it's not regulated, it can eventually cause permanent blindness. So that was number one, you know, traumatic situation of health. We got that under control with the help of my neurologist. He is the one that actually suggested weight loss surgery. And I got approved for the weight loss surgery. At the time, lap band was the big thing. I did the lap band in 2009. At my highest weight of lap band, I was at 290 pounds. And I got down to 115 pounds. Now, by all outside looks, I was successful. I cheated it. My dad had gotten diagnosed with cancer in 2009, and I wanted to prove to him that I could lose the weight. So you figure out a way around the band. Kim, you know where I'm going with this. You figure out what slides and what doesn't. And anybody that's had lap band or any type of bariatric surgery, you know when you eat something and it gets stuck, immediately you know that look. Hang on. Whew, I don't
I've
talk
got you.
about all
It's a
this
safe
stuff.
space. I know.
I
It's a
know.
safe space, though, especially with me. You know that.
Yeah.
Kim is known to break people into tears. It just happens. So go
I didn't even do
ahead.
anything.
Whew,
All right, make you laugh a little.
I know, right?
Right.
Got you. Got you.
So I realized that I could get stuck and get rid of the food. And I let this happen over the course of not months, a couple years. And essentially, I became bulimic to the point that it affected my relationship with my sister, that she would not let me around her kids because she didn't want her kids to think that that was acceptable. But in my mind, I rationalized it because when it came up, it was solid chunks. It wasn't all the gunk. So I made myself think that it was okay. And if it came up, it's fine. I'll just go back and eat a little bit more and see if it'll stay down. And that happened for a few years until it finally caught up with me that I ate something I shouldn't have and my lap band got stuck. Had to go to the emergency room, have it deflated. And then we were going to slowly build back the fluid to where I could get back to the restriction level that I needed. And I was going to do it smart this time. But, life happens. I just didn't keep up with the pills. So now that's around 2018. My mom passed away in 2020, but I was continually, gradually putting the weight back on. And then we fast forward to May 2023. I was now at my heaviest of 292 pounds. And I started having some chest pains. And I've never had acid reflux. I've never had any of that. So I thought, well, maybe it's just some acid reflux. So the first time it happened, I went and grabbed an ice pack and sat it on my chest, went and laid down for like about 30 minutes and the pain passed. I noticed that I'd gotten really, really sweaty when it happened. So it passed. And then about 3 or 4 days later, I was up late working one night and the pain hit hard. And it's right here in the sternum. And I told my boyfriend, I was like, I think I need to go to the emergency room. And when it happened, I had gotten super, super hot. And I told him, I was like, I just need to go lay down on the tile bathroom floor where it's cold so I can try to like cool off a little bit. And at one point, I know that I was actively starting to pass out because he was talking to me and I could not make out what he was saying. So thankfully, we literally live right across the street from a hospital. So we were actually just able to go over there, went in, and they had me in the waiting room for quite a long time, to where the pain had subsided. They put me on like some saline just to try to rehydrate me and stuff like that. And then while we were sitting there waiting, it started happening again. And this was an unbearable pain that I can't even describe. It was worse than my worst migraine. And so they ended up admitting me, and they did angiograms, CAT scans, all the testing that you could do. And come to find out, I had a heart attack. So it was initially described to me that it was spontaneous coronary artery disease, dissection, which is where within your arteries there's a lining, and that lining tore. And when there's a tear in the lining, what happens is that as your blood flows through that lining, it starts to pillow and pocket in that tear, causing your artery to eventually possibly close. It's known to be, from all the research I've done, it's known to be most common in women ages like 40 to 50. Usually they've undergone like a recent traumatic event or a recent stressful event, like a dramatic pregnancy or something like that. And my cardiologist was so baffled because he asked me, he's like, have you had anything like that? Like, have you had a traumatic experience? And I was like, no. I'm like, the only stress I really have is just work, and that's it. So they kept me in the hospital for about 3 or 4 days, and They said it was SCAD, the SCAD, but then they also said at some point within that time frame I had a heart attack. So now we know what we're working with. I get out of the hospital, and if that's not a wake-up call, I don't know what is. And so I then decided, okay, we got to get serious about this, because clearly your health is not in the best shape. So I then go back to my bariatric surgeon, wanted to get the band filled so I could start losing some weight some more. They send me off for an upper GI, and then I go back to the surgeon, and he says, well, we're not going to fill you. And I go, why not? He said, because according to your upper GI, you're at the restriction level you need to be. I was like, clearly I'm not. So then I didn't receive any additional support from them, no recommendations, just that's all we can do. Oh, but you can take my copay money, I'm sure, for not telling me anything. Then I decided, okay, well, it's up to me. I've got to figure it out and do what I got to do. So I started looking up like calorie deficit eating. What can I start changing things out for? And I started working on that, and I was having a little bit of success. I mean, within about a month, I dropped about 10 pounds just making lifestyle changes, and I cut soda completely. Haven't had a soda since freaking July, I think, which is amazing. And then about 3 weeks after my heart attack, my friend messaged me and just checking up on me. And she's like, hey, how are you? I'm like, oh, I'm good. I've lost this much weight, trying to do it on my own. And she's like, oh yeah, I lost about like 13 pounds in 13 days. And I was like, I'm sorry, what? Because I had already started researching these medications, but I don't have health insurance. And so I didn't think this was going to be something that I could even think about. So she told me about compound, and I was like, I didn't even know this was a thing. Let me start researching. Enter TikTok. I was not a TikTok person at all, but I can't tell you, I've learned so much about this medication on TikTok that now my friends are coming to me asking me questions about the medication. So that's been amazing. So I got compounded semaglutide, started that on July 13th. I am currently now down 57 pounds as of this morning. And to say it's been a game changer is an understatement, because from the idiopathic intracranial hypertension aspect of it, it is helping with that, with my migraines. It is helping with my blood pressure. I'm currently still on a statin and blood pressure medication just as a precautionary situation, but blood pressure's come down, and I just overall feel so much healthier with everything, with the way it's going. So that's the biggest nutshell that I could put it into. But I am so appreciative of these medications, what they do. I shout it from the rooftops, and I know that I would not be here where I'm at today had it not been for this community and this podcast. So that's my story in a nutshell.
I love it. It was awesome. I
Thank
think
you.
it's really interesting how many people we meet that like the language that they use when they're talking about like tricking the lap band and things like that, right? And like I think for me, we're friends, is that I have learned to forgive myself
Mhm.
because like it really is just your brain that thinks it's starving. Like,
Yep.
you know what I mean? Like it really is. Like, and
Yeah.
it makes you feel like you have to do it until it's all you can think about, and then you give in because you
Yeah.
are just a biological creature, like,
Yeah.
and it's helped me so much with that because there was so much of the like negative self-talk. And I think many of our friends that have had any kind of bariatric surgery, say the same types of things, and like, I hope that it's helped you with that too.
Oh
Yeah.
yeah. That's one of the biggest things that I learned, is that what the bariatric surgery can fix mechanically within your body, the GLP-1 fixes your brain. And that was the missing element of all of it.
Yeah, the
So, yeah.
biology.
One other thing that I want to bring up, after my heart attack, when you're in that headspace of trying to figure out what is your next move and how do you get to your healthier state the quickest, something that people do not talk about is you mentally go through a state of depression. And y'all's podcast with Dr. Toomer, I remember it clear as day. I was driving on the road and she dropped the bomb of cardiac depression. And as soon as she said that, I was like, that's exactly what I've been feeling, because you go from this state of being in a hospital, getting treatment, now you're out and your brain is going, when's it going to happen again? So you are constantly on edge. And when I tell you that the depression lasted a good solid month to where I didn't work, I would sleep all day. And because your body's in that constant state of trying to heal itself, I found myself that I would get bursts of energy and work for like 3 hours, but it would completely zap me after the heart attack. And so that was something that was huge for me, and pretty much a pivoting moment when I learned about the ideology of cardiac depression, because now I could identify it, and now I could say, okay, this is what this is. So now I can pivot and get myself out of that state. So that was something I feel was super, super important for anyone that has ever gone through this, that now we have a terminology that we can identify it with. So that way we can move away from it when we can.
Yeah, I love that. Quick brag on you. I love how introspective you are. Thank you for sharing that.
You're welcome.
Truly.
So what I'd like to do is invite on our medical guest this evening, for all the validation and the things.
Yeah.
And then we can go from there. Okay. Well, hello, Dr. Lee. How are you? Oh, you're on mute.
Uh-oh.
Hello, Dr. Lee. How are you?
There you go.
Thank you. Thank you so much for having me on and sharing your story, Priscilla. Wow, so powerful. It's a real honor to be here.
Awesome. Well, we're so glad to have you. I would love if we obviously know you, but I would love if you could tell our audience a little bit more about who you are and how you help people.
Absolutely. So I am a cardiologist. I'm based in Boston. I have a little bit of a black sheep background. I mean, I'm a little different, and always have been. I grew up in a big family of doctors, like a ton of doctors, and I was drawn to sort of medicine very early on, just because I saw how directly my parents were able to help people in their average day. Something that you guys are used to actually on this podcast. But as time went on, I just realized, wow, there's so much more to healthcare than just medicine, and health than just medicine. And so I wanted to learn a little bit more. I wanted to think about, like, how do we deliver the health to the people who want it or need it, right? It's not just about diagnosing disease, and it's not just about like meds. And so I learned about the existence of these programs that combine a medical degree with a business degree, and was like, that seems like a great toolkit. Was lucky enough to get into the one at Harvard, and it was great. It was really great. Obviously learned a lot on the medical side, but what I didn't expect was just a ton of learning on the business school side. I mean, really a lot. And I think that one of the things that really came out of that experience was just how many different avenues of potential impact there are outside of just normal medicine and the normal medical pathway, whether it's content and, like social media marketing, podcasts, or whether it's entrepreneurship, or even just like large corporations. So I kind of was very, drawn particularly to the content marketing and also entrepreneurship side, filed that away, went on to clinical training, landed in cardiology with a brief detour in neurology. And Priscilla, your story is like pulling together everything for me. I initially thought that I wanted to be a stroke doctor and love neurology. I actually married a neurologist. But in the first year of medical training, they make you do a general sort of intern experience where you see all of medicine. And luck of the draw, I just had like 8 straight weeks of cardiology, and I totally fell in love. I mean, it was like the lightning bolt soulmate effect. And I knew that I had to divert. I wasn't able to do that without going on to do 1 full year of neurology. So I got a ton of immersion in common issues that you've already touched on that have affected you: migraines, obviously strokes, clots in the brain, and IIH, or idiopathic intracranial hypertension, and then came back to cardiology. And timing is everything, right? I mean, I started the cardiology part of my journey right as the pandemic was like really taking off. I also just like rounding out who I am. Like I had just become a mom of, my first of now 2 boys. And it was a crazy time. But I think what was happening was all the care went virtual, which was appropriate. And then as the shutdown stopped, or like all the restrictions were lifted, a lot of my patients came back to the clinic. And I really remember this one moment where I walked in to see one of my first patients coming back for their first in-person appointment in like years. And I didn't recognize her. Like it was so awful. It was mortifying for her and it was mortifying for me. But I had my little chart, had my little piece of paper, and I'm just like striding into the exam room, ready to, hug it out and hear all about how she'd been. And I didn't recognize the person in front of me. And I, for a moment, thought, wow, I'm in the wrong room. And I'm looking at the paper and everything and realizing, no, I'm in the right room. She had gained 30 pounds during the pandemic, like so many. I mean, between being cooped up, sedentary, stressed, wildly stressed, unable to get access to care, it was a recipe for, metabolic and cardiovascular health deterioration. And so I just saw that, one patient after another. They didn't look like their former selves. They shouldn't feel like their former selves. And all of their heart disease risk factors had just gotten completely out of control. Blood pressure was through the roof. Cholesterol levels had increased. And some had gone on to have from no glycemic control problems, no insulin resistance to prediabetes, or from prediabetes to diabetes. And then, of course, there are people who, like you, Priscilla, had actual heart attacks or new heart failure. So it was awful. It was a little overwhelming, to be honest. And I think the thing that made it very challenging was that where normally cardiologists would draw a boundary and say, okay, weight, yes, it's a really significant risk factor and cardiovascular issue. Let's refer to our obesity medicine colleagues. I couldn't get a patient in to see my obesity medicine colleagues before 18 months. That's how long our wait list was at a top-notch Harvard-affiliated hospital. So, under the mentorship of my, this master clinician who trained a bunch of us, who actually was my grandmother's cardiologist and trained with my parents, so very close family friend and mentor, he took this very proactive stance and said, these people have already been waiting for years to get in for care. And it's going to be over a year before they can see the endocrinologist, the weight management specialist, maybe even their PCP, to be honest. So if we don't take advantage of the 20 minutes that we have with them when they're right in front of us and start treating their weight and treating their blood sugar and insulin resistance and treating their blood pressure and treating their cholesterol, we're going to be seeing them back in the hospital or after they've been hospitalized for a heart attack. And so that was really like the philosophy. And it was rewarding. It was incredibly rewarding to start prescribing GLP-1s as a major tool in the toolkit. I mean, it wasn't the only tool, but it was a big, big tool for us. And to just watch, the transformation that you all have articulated so beautifully on your own platforms and here on this podcast, not just sort of externally with all the labs and all the little medical data that obviously we nerd out on, but internally, and just before we went live on the show, we were just talking about like makeup and hair and like being able to look yourself in the mirror, right? And to be able to like love oneself. And so it was so rewarding, but I kind of took a step back and thought, wow, here I am, one person. I'm one of like 2 in this entire division of like top-notch cardiologists at a top-notch hospital who's like being very aggressive in this way and proactive. I see patients once a week. This is not a scalable operation, right? Like this just isn't going to work for the 230 million people who have overweight or obesity in this country. So, and combined with the fact that there are only 5,000 obesity medicine doctors and 8,000 endocrinologists, like this isn't going to work. The numbers don't add up. started to think about how I could help, how can we solve this access problem, and decided, to go, again, black sheep from MD MBA to like now going in this different direction, decided to build a business that would provide more accessible care. And so we are building, our company's called Systole. Systole is the moment when all the heart cells squeeze together to send blood forward to nourish the body. And it felt like a great metaphor for providing group-based virtual care, not one-on-one, but to have doctors see groups of patients. In our case, we're focusing on women first, who are suffering from what we call cardiometabolic disease. So it's obesity, diabetes, blood pressure, cholesterol, or some combo. To broaden the access to care, but also to leverage the power of what you all see day in and day out, community, right? Like people, women helping each other, sharing the successes, sharing the struggle, leaning on each other, practical tips that frankly, like a lot of us doctors just don't know how to manage the side effects, how to like deal with the ups and downs of just being a human being, navigating the stigma, right? So anyway, that's what we're doing. That's who I am. I also, to the fitties here, like, just going to add a little asterisk. I'm also a fitty. I'm a runner. I survived the Boston Marathon yesterday. I'm so grateful that this podcast does not require me to move at all, except my mouth. I'm just sitting here in pain. And, we say the glutes, that's the technical term. And I would say that there's nothing left of those after yesterday. So anyway, what an honor to be here. And obviously so much to dig into, but I think Priscilla's story was the perfect sort of springboard, because so much of what she's been through really mirrors the types of patients that I take care of all the time and that inspired me to go in the direction I'm going in.
And like, I do feel like when I was listening to her talk, I was thinking about, like, I hear so much, like, I don't want to call it self-diagnosing. Do you know what I'm saying? But like, I think that we have a lot of doctor aversion.
Yes.
Right?
Understandably.
Yes, because for so long we've had this like poor experience, right, with many doctors. And I think that like, so I have come to a place where as long as doctors are evolving toward like, as long as they're like, like I didn't know and like I know now and I'm doing better, like, and they actually are doing better, then I'm cool with it. If they're not, then like I'd say fire them. But like if they are, like I can, like I get to a kind of a place of forgiveness. But like I do think it runs very deep. Even I still struggle to go to my doctor when little things happen, and I should. Like I literally preach this shit. You know what I'm saying? Like, and I think that it's just the trauma runs very deep, and there are not enough obesity specialists. There are not enough endocrinologists. There's certainly just not enough, even cardiologists. Like there's not enough of these people that really, really understand this disease and these medications.
I mean, if you
Why we
flip
do
the
this,
switch,
right?
if you flipped a switch and made every PCP in the country, primary care provider in the country, competent with the treatment of obesity and other cardiometabolic diseases, that would still mean one provider to every 46,000 patients with overweight or obesity.
Jeez.
That's not going to work. The average panel size is like 200, 300 patients. It's not going to work. So the system, and then of course factor in like personality and compassion and right.
For sure.
Chemistry.
And I do think that's why it's so important to have things like, nurse practitioners and things like that, because we need to be able to extend the care. And that has been a very big mission for me in terms of, frankly, kind of who I want to advertise on the podcast, and what resources I want to bring to my community. And of course, there are people who are like thinking with business, like, but how can it just be me? And I'm like, because it can't just be you, right? Because if you could be the most amazing thing and serve my entire community, then if you could serve at least 40% of America, then you know what? We'd work it out. You know what I mean?
Right.
But you can't. So that's why I take it really serious, and so I'm so thankful for finding like quality care and being able to bring it, to people here. And they know that, at least I've looked into it and taken it really serious, So I think it's great. I mean, I think that having more access, and you describing kind of what happened with COVID, like it's like that was the problem with healthcare in general, right? And now it's like that is for sure the problem that has continued for obesity. Like it's just getting worse.
And worse. Yes.
So I think it's great. And I love the community baked in. I think many of us can agree that one of the biggest differences is this time, and this time is the last time, is the community, right?
Yeah.
Is having that like baked in piece of support. And it's very different than going to like a message board and seeing people post as it is to seeing people in their everyday lives and speaking to you like you were their friend, you know?
Yeah.
So I think it's really cool that you offer that in your program. That's awesome. Yeah.
Thank you. No, I think it's amazing. This community truly, it's like I've been trying to explain to other providers who are sort of curious and
Yeah.
pharmaceutical companies. I mean, you know, if people want to see the power of community, whether it's for education, information transfer, or just sort of, you know, health advancement, right? Like mutual health advancement. This is example 1A, you know, it's been amazing to sort of really observe and learn.
I think it's cool too, like just like with TikTok in general and how fast it moves.
Yes.
And kind of in a way that it's almost out of control, which is what makes it magical,
Yes.
you know, especially with medicine, because medicine moves slow, you know?
Right.
And I think that's, I mean, you know, things are changing there, but I think that what's cool about it, so like I was talking with, and we make this, I don't know, but I was talking with a reporter from Bloomberg, and she said, really, it's a fascinating community and it is driving the conversation, like, period.
Wow.
Right. And it's true. It is like, we are not a part of it. We're starting it. Like, that's why when Oprah came on and she was like, we're going to start the conversation. I'm like, girl, you've been gone a year.
You were working on Color Purple.
I love you forever, Oprah, but no.
Yeah, she's just showing up fashionably late.
I'm okay with that. Everybody knows I'd forgive her anything. Sorry, Kat, ask her question.
You're fine. That's fine. No sorry needed. Your platform. I got to lurk on your platform a little bit, and it was fun. Your platform on, of course, is heart health and obesity management, and we know all that we're all under we have the impression, or we know that obesity management does help with your heart health, can help strengthen our hearts. But could you actually give us some specifics, like some of the specific correlations of heart issues and obesity and how they develop over time?
Great question. I mean, it's like one of those things where like everyone knows that there's a link, but like what exactly is the link?
Exactly.
What are the steps? And like how big is this effect, right? I mean, I actually find this is like really powerful information to share, not to like add to any shame or anything, but just to also like help motivate people as they're starting to catalyze their journey and starting to have some progress, whether it's medication assisted or not. So, I mean, I think zooming way out, big picture, let's just start with obesity reduces life expectancy. It cuts off years of your life, okay? And I mean, I think the clearest way that we saw this is like life expectancy in the United States was increasing for 160 years. And then we hit the early 2020s, okay, when like everything got so much harder for so many reasons, and it decreased for the first time. There were a whole bunch that really hit the headlines. And this was attributed to like the opiate pandemic, COVID, obviously, mental health issues with increasing suicide rates. But what no one was really talking about was also obesity. Obesity rates had really been increasing in the background. And just to like, in the spirit of specifics, I mean, you know, if you're in the BMI range of 30 to 35, your survival is reduced by like 2 to 4 years. If you're in the 40 to 45 range, your survival is reduced by 8 to 10 years. So these are really powerful depressing effects on life expectancy. And that, you know, many believe was also driving down, you know, the first time decrease in our country's life expectancy. I think it's important to note a little asterisk here is that obviously there's obesity defined in terms of BMI, but we all know that BMI is not a perfect metric, and that, you know, the fat tissue deposition, distribution and around the abdomen and abdominal adiposity really matters a lot. That sort of is what is biologically linked to like insulin resistance, cholesterol issues, and heart disease risk. And so there is, of course, a big association there. But like, so why is this happening? Why is obesity so lethal, you know, and so dangerous? And the reason, what we say in cardiology is that obesity counts twice when it comes to heart health or heart disease risk, because it by itself is a risk factor for heart disease. And I'll get into that shortly. But not only that, it's also driving all of the heart disease risk factors that are not obesity. So it's kind of like, doubly risky. And so what are the things that it drives that are heart disease risk factors? These are what we call cardiometabolic diseases. Obesity is one, but here are the other risk factors. Type 2 diabetes, okay, which is a problem related to insulin resistance. And, there's research out there saying that more than 80% of type 2 diabetes out there is attributable to diabetes. So, for numbers, and that, like weight loss around 15%, which is very hard to achieve without medication assistance, like with GLP1s.
Yeah.
But if you're able to get there, it can actually lead to reversal of diabetes in nearly half of the people who are in that bucket of that category of weight loss. So there's diabetes, there's high blood pressure. We see high blood pressure is so prevalent. It's like 1 in 2 adults have it, but among people who have obesity, it's definitely at least half of the population. So, that's a big risk factor there. High cholesterol and abnormal fatty lipids, which we call triglycerides. And then there's also sleep disorders. So obstructive sleep apnea is very closely linked to weight. And on the other side, very closely linked to all kinds of cardiovascular problems, whether it's high blood pressure, again, creating this sort of vicious cycle of risk, or arrhythmias like atrial fibrillation, which increase your risk of stroke, coronary artery disease like heart attacks. So, all those risk factors are driven by obesity, and then out the other side are driving heart disease. But as we said before, obesity also drives heart disease itself. It's an independent risk factor for heart disease. And so heart disease is this really big category of things, which again, like I feel like the medical establishment, healthcare professionals don't do a good enough job of explaining, like, what do we mean when we say heart disease, and what exactly are we talking about? So the big buckets are coronary artery disease, which refers to cholesterol blockages building up in your arteries. And the fear is that they, rupture, they become unstable and cause a heart attack. Obviously, the kind of heart attack that Priscilla was talking about at the top of the episode is sort of a, happened by a different mechanism, but we can probably get to it later, how this may still kind of, link together a bunch of the different biological effects of obesity. So blockages leading to heart attacks. And the other big bucket is heart failure. And then there's sort of like arrhythmias, electrical problems that can lead to sudden, death related to the heart. And so for coronary artery disease, blockages and heart attacks, when you look at these massive meta-analyses that pull together all the research from dozens of trials representing tens of thousands of patients, they looked at we look at the connection between BMI and coronary artery disease, and there's a 29% increase in new coronary artery disease for every 5-unit increase in your BMI. It's crazy. Again, there's a lot of data to suggest that this is worse when you have that BMI distributed around your abdomen. It's because of everything we know, the cholesterol, the inflammation, obesity also with like the problems with insulin increases the activation of your sympathetic nervous system, which is your fight or flight response, which increases your heart rate and your blood pressure. Again, just like vicious cycle. And then there's heart failure. So this is really interesting and very important in terms of like how common it is. There's the kind of heart failure where your heart just gets kind of like big, baggy, and weak. Sounds terrible, but like we call that heart failure with reduced ejection fraction. That's a weak heart. But the much more common kind of heart failure is heart failure with normal strength, just kind of stiff. And that's very common in obesity. So that kind of heart failure, the risk of getting it is increased twofold in people who have obesity compared to people who do not. There's more that we can say about, the unit increase for every unit increase in BMI, but like what's going on there? I mean, there's just so much pressure on the heart from the excess weight itself. And then of course, obesity increases how much volume you have in your blood because you need more blood to like feed a bigger body. So your heart is getting overloaded. It's like, being overpumped full of blood, which causes it to kind of try to change its shape to accommodate all that blood. And it gets a little bit thicker and stiffer, On the other side of things, you have high blood pressure frequently from obesity, and that's kind of like kinking a garden hose and then trying to pump against it. So that adds more stress in the direction of a thickened, stiff heart muscle. And we see this, on all kinds of cardiac testing that Priscilla probably had a lot of, like echocardiograms and, now they're cardiac MRIs, which can show that there's scarring related to this, there's fibrosis related to this. So that's how you end up with heart failure. And finally, there's some evidence, growing evidence, that there might be like increased risk of arrhythmia with obesity. One of the most common is atrial fibrillation, which we were talking about before, can cause stroke because of blood kind of pooling in a top chamber of the heart that's not really pumping well. But there's also issues with more dangerous arrhythmias that, is under exploration right now, but might explain sort of sudden cardiac death. So there's a big, big connection. My mantra around all of this is that weight is heart health. I mean, it's not just a risk factor. It independently, drives heart disease. It changes sort of how the heart functions, even if you've never had a cardiac event, and it's driving all these other risk factors. So that's sort of, long answer, but hopefully one that, satisfies the need to have a little bit more data, a little bit more specifics, as opposed to just, this isn't good for your heart.
Right. No, that's
No,
definitely a lot.
So we'd rather have too much data and too
All
much
the
information
details.
on yeah, like that's why we're here and not TikTok. So,
Exactly.
We caught one of your TikToks discussing male and female reactions to GLP-1 medication. Are there differences between tirzepatide and semaglutide? And is there a trend among men and women in one more than the other?
So this is a very interesting question. There appear to be sex differences, like differences in how women versus men respond to GLP-1 medications. But most of this data is from studies looking at earlier GLP-1 medications that are not semaglutide and tirzepatide. So liraglutide, which is Saxenda, Victoza, dulaglutide, which is Trulicity, or exenatide, which was the OG GLP-1 that I've never seen someone on. I'll just quickly summarize what that data shows, and then we can talk about emerging data on semaglutide and tirzepatide. So the early trials are done mostly in diabetic populations, and as I said, with the earlier generation GLP-1s. And what we see in general is that women tend to lose almost 2 times as much weight as men. But on the other side, the sort of other side of the coin is that they're twice as likely to encounter side effects, particularly of the GI variety that so many here will be familiar with, compared to men. And so why is that? Some people have wondered, are women just kind of on average starting out at a lower body weight than men in these research studies, and they're effectively getting a higher dose? It's certainly possible, but there's other study that has suggested that estrogen is playing a role. And this gets very interesting, but we know that when you lose estrogen in menopause, rates of insulin resistance go up and rates of diabetes go up. But we also know there's a Goldilocks thing going on where too much estrogen when you're pregnant, for example, might also dysregulate your insulin and your body's responsiveness to it. It seems that in studies that are not done in humans yet, this is all based on animal studies, that estrogen seems to somehow modulate the food reward aspect of food signaling, so of food seeking. So, there are actually some early studies in animals where they're looking at co-administering GLP-1s with estrogen, and they show that that combo has a synergistic effect on activating this part of the brain called the supramammary nucleus, which controls food intake. It basically has a bigger depressing effect on food reward behavior. Think about food noise, right? We hear that term all the time on TikTok. Something about estrogen in combo with GLP-1 helps make the reduction of food noise more pronounced. And so scientists in this research community looking at GLP-1s have wondered if, aside from drug exposure and, your starting weight, if something related to estrogen is going on for this big difference we observe in GLP-1 effectiveness as well as GLP-1 adverse effect rates. So that's kind of what we know from the earlier studies, mostly in diabetics. Semaglutide and tirzepatide, we still haven't seen data that analyses of the big clinical trials, sub-analyses, I should say, that specifically focus on differences in men versus women. But I will say that unlike almost every research study and clinical trial that's done, women were overrepresented, were generously represented in the big semaglutide and tirzepatide trials, around 70% of enrolled participants. So it does give a little bit of a clue. So we'll see. We'll keep looking for future analyses that I'm sure, the team sponsored by Eli Lilly and Novo Nordisk are working on in the background.
Oh yeah, they'll put it out. That makes me think of, all those jokes about women we're hangry. We go,
Yes.
we're grumpier when we're not fed or things like that. There's actually a lot of credence to it,
And I mean, it's been well described just looking at menstrual cycles, women, it's been shown that there's less food intake during the early part, the first half of the menstrual cycle when estrogen levels are lower, and then greater food intake when estrogen levels are higher. So that's further suggestion that estrogen is turning the dial up and down on how much reward we get out of food.
Yeah. All those dang hormones, right?
Hormones.
All right. So we heard some promising benefits about obesity treatment medications and the benefits that they create for heart conditions. Number one, can you expand on the medications and how they help? Additionally, I want to add this just personally because a lot of my friends will say, well, of course, it's going to do better for your heart because you're losing weight. However, I want to find, is there an actual correlation? Like say the study that came out that said wegovy actually improved heart conditions. What are those clinical results besides the actual weight loss?
Yes. So great question. All of this exciting discussion around GLP-1s and improving heart health or preventing heart disease really comes from one big study, which was called the SELECT trial, which was presented and published at the end of 2023. And so in this study, they looked at semaglutide in patients, adults who had already had heart disease. And how did they define that? I mean, most of them, 2/3 of them had a history of heart attack, but they also included people who had strokes or who had blockages in their legs or had a heart stent or bypass surgery, something like that. But most of these were heart attack survivors. And they were in their early 60s, BMI 33. Most were actually pre-diabetic. So it's not like this was a totally normal sample in terms of insulin resistance. And their cholesterol and blood pressure was pretty good at baseline, pretty close to, because they were on statin medications and probably other medications to help control blood pressure, which is a major risk factor. And they randomized this big population of patients to get semaglutide at 2.4, the maximum dose, or placebo, fake medication. And then they followed them for only 40 months, as opposed to some of the other GLP-1s trials that look way out to 72 months, okay? And in that short time frame, they saw a 20% reduction in cardiac events like heart attacks, strokes, and death from heart-related causes. They also saw fewer heart failure hospitalizations and events. So this really had a much larger than expected effect for a shorter than expected time frame, over which people lost not as much weight as we see in the obesity studies, 10% weight loss on average. So we'll get to sort of your question about, is it the weight or is it some, I think we can even get to it now. Was this outcome because of weight loss? 10% is a lot, but over just 40 months, it'd be hard to attribute that magnitude of a cardioprotective benefit to 10% weight loss. So what else could be going on? This is where we sort of draw on other research that's been done on the impact of GLP-1s on the cardiovascular system. So we know that it improves the function of that innermost lining, the endothelium, which is what dissected and caused the heart attack in Priscilla. It helps the endothelium and the blood vessels relax more, which helps lower blood pressure. It also helps our body get rid of salt. We know that salt isn't amazing for us. GLP-1s promote release of something called atrial natriuretic peptide, or ANP, which is sort of like your body's natural blood pressure medication. It makes you urinate out salt and, make the kidneys work better, and with that control your blood pressure better. But then it does like a bunch of other things that are amazing for your heart health. It decreases inflammation. We know obesity has a big inflammatory component in its biology. Yeah. When you measure markers of inflammation, this was as much as like 39% in this big study that we're talking about. And then it also decreases cholesterol levels. So, your bad cholesterol, LDL, by 5 to 7%, triglycerides, those fatty acids, by up to 25%, depending on the medication. And so all of this together in aggregate is probably why we saw such a pronounced protective benefit over a shorter time frame for like a medium amount of weight loss when we think about all GLP-1s. So that's sort of what we're looking at. And tirzepatide, a similar study is underway. And hopefully we'll see those results soon, but TBD, we're all sort of waiting on the edge of our seats.
Yeah. That's good. Mounjaro, or tirzepatide, what I am on, has definitely helped reduce my cholesterol. Although I kind of sort of attribute it to, I didn't realize how many eggs I was consuming in a day just to get my protein in. And I had my blood taken and I was like, whoa. So it's egg whites for me.
Oh, egg whites. Gotta love them.
I was so glad to see that number go down, though. Woo.
Yes, it was so rewarding. It's really rewarding, isn't it?
Yeah.
Really. Let's chat about retatrutide that was recently in clinical trials. It's a triple G agonist. Could you help describe what the medication does, and also talk about the trials showing that it increased heart rate in some individuals? Should that be a concern for all?
Great question. So retatrutide is something we're all very excited about. It is as you said, a triple agonist. So it stimulates the receptors. It basically recreates the effects of 3 hormones: GLP-1, which many are familiar with, GIP, which is also involved in the mechanism of tirzepatide. And how is that different? It has many of the same effects as GLP-1, but it also, we think, increases your body's like basal metabolic rate or energy expenditure. And then it also stimulates glucagon. It recreates the effect of glucagon, which is like the yang to the yin of insulin. It's like the foil hormone for insulin. And also, we think, reduces energy intake, like food intake, but increases energy expenditure, like how much your body is just burning on its own. So that was sort of that's the science behind why they created this triple agonist, as opposed to just sticking with new versions of GLP-1s only. And when they looked at a phase 2 study, so looking at safety in like 300 or so adults with obesity over 48 weeks, they saw that in the people who got to the highest dose, mean weight loss of 24%, which is so much more powerful with these medications. And also not even the triple agonists or double agonists like Mounjaro, zepbound, but even in the older GLP-1s, we have seen an increase in the resting heart rate, but it's not very much. It's like 2-3 beats per minute on average when you look at all these research studies. And why is that so strange? Some people think that it's because of the promotion of these medications of insulin release. And insulin, when you release insulin, one of your body's responses is to, have a little bit of a heart rate surge. The other sort of effect downstream of that is that insulin increases the activation of your sympathetic nervous system, which we talked about before, sort of your fight or flight response. And that can cause some elevation in your heart rate. Most people don't feel this and might not be aware unless they're sort of tracking with some kind of watch or something like that. But of course, there are people out there who might have a heightened sensitivity to fluctuations in their heart rate. They might feel some palpitations. In general, like it takes, there's no there's no major contraindication related to, like POTS or some kind of arrhythmia like atrial fibrillation that would make
Okay.
a doctor say, oh, we shouldn't start it because it might increase your heart rate by 2 points. If someone has a history, we might just monitor them or make sure that we check in about what their watch is showing and that kind of thing. So retatrutide is an exciting new dimension in the frontier of obesity and heart health research, and we can't wait to see the next phase of next phase study results.
That's going to be really cool. That's going to be great to
Yes,
see. I'm excited.
absolutely. I know.
So do you think they think that'll be released in 2025?
Oh gosh, I don't know. I know it's underway. I don't know. I don't know when, but boy, we cannot wait.
I'm excited about it because I think I probably, I don't think I'll lose much more. I mean, 100 is way more than, it's like 2 or 3
Right.
times the
Right.
amount that they thought that the study showed.
Yeah.
So I don't think I'm going to lose anymore. So I think unless I do what I've done in the past, which is just like dramatically, like, I mean, I don't even
Limit.
anyway, but you know what I mean? Like, I mean, unless I just diet my face off. Do you know what I'm
Right.
saying? Like,
You don't
I
wanna do
did
that.
all this to have a better quality of life, and I'm just not doing that.
Right. And it'll be great for patients to have, more options. And then, the more options there are, the more the accessibility problem will improve.
Yeah,
We
for
live in a
sure.
capitalist society. There'll be pressure on the price point. And, so whether it's retatrutide, whether it's other GLP1s, GIPs, or just GLP1s, I mean, the more drugs that come to market, the better it'll be for patients.
I'm excited to see them come to market with things that aren't injectables.
Yes.
Because I think that if we can get people that are more afraid of needle, I feel like a lot of people get past that. But clearly that supply chain issue is one of the biggest reasons, right? That we have these shortages. And so I hope that there will be more options like with oral medications,
Oral or just vials.
Yeah,
Yes.
whatever.
Amen.
Shoot it in your eyes, whatever.
Men.
Spit on your tongue. Have a lozenge. Sorry.
It could be a lozenge.
Those are all real things on TikTok, by the way.
Oh my gosh. Wow.
Yeah. Oh yeah.
There's genetic therapy.
Oh, it's bad. Like,
really? Genetic therapy?
Yeah, there's some really
I heard about
interesting
that. Yeah, tell us
genetic therapy. There's a company actually based in my lovely little home state, Massachusetts, called Fractal, and they've devised a way to essentially turn on GLP-1 through gene therapy that is delivered through an injection to the pancreas, which, you wouldn't do through the skin. You'd have like an endoscopy procedure to have that done. And they've only done this in mice, but so far when they look at mice on semaglutide versus, getting this gene therapy, more pronounced weight loss that lasts longer. And so I think they're starting, my sense is that they were going to start human trials this year. So that's another sort of direction that the research is going in.
To get them on the show.
Wow.
Yes. No, I know. Can you imagine having it turned on all the time?
Yes, please.
Without the fluctuations based on the drug level.
Yeah, because like that happens to me like towards, like the end. Like you guys I'm sure you can tell how thin my face looks today. It's because it's shot day. And so all the inflammation just goes from like here, like,
And then the fatigue and, the fluctuations in appetite suppression. Yeah.
True.
Sign me up for that trial.
Yeah. Oh my gosh. It's like, I'm all in.
It has to go down through, so you have to like put to sleep to.
You would, yes. I mean, endoscopy. So, if you've had it, you know what it's like. Yeah. But if you haven't, basically you'd be sedated the way, like colonoscopy type of sedation, awake, but not like so knocked out that you can't breathe. So, and then they put, a cable down your throat, into the esophagus and then into the stomach, and then from the stomach to the pancreas, and pop a little needle over to deliver the treatment. Yeah. I mean, I'm sure I can't imagine doing this in a mouse, actually. I'm really impressed that they can do it in a mouse, but they had great data in mice.
These days for surgeons. Seriously, I'm not being dramatic. I mean,
what did you say, Kim?
They have little robots to do surgeries these days.
I know. I know.
Fascinating. That's what Dr. Rosen said. He goes, I'm not like the kind of surgeon you think. I have little robot hands, and I go poop, 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 poop. I was like, great.
Take
sign
the
up for
human
that
out of
surgery,
it.
Dr. Rosen. Geez
Yeah.
Louise.
That does not sound like a cheap procedure, though, if you think about it. But
Right. And
cool.
so, there's a version of this kind of gene therapy out there for sickle cell disease now. And like, yeah, it's
Oh, that's amazing.
I think the price tag was over $1 million for a disease that affects a lot of people, from a low socioeconomic background. So of course, that's going to be part of the discussion. We don't want obesity treatment to just be something reserved for the wealthy, right?
But then we could say we get all the shots back, right? That's been the whole thing. These celebrities are taking the shots. Well, they can go get the endoscopic injection,
That's
right?
true. That's true.
They can get the fancy
There's
one,
plenty
and
of
we'll
them.
have our little shots.
Right.
All right. Okay, we'll get back to business. So we got, many of our audience is women, and a lot
Yes.
of us are approaching menopause or perimenopause. Just some really good preventative, helpful things. Could you provide some things we can do to keep our hearts healthy approaching this time? And also, do you experience any cardiovascular changes during menopause as well?
Absolutely. So there's a lot of important cardiovascular changes that happen during menopause. And I think in terms of keeping your heart healthy as you approach menopause or navigate menopause, it's like awareness of this is probably one of the most important things, because the average provider is not necessarily going to be sitting there like proactively educating you on this. We know that women of menopausal age and menopause related concerns are often neglected and under sort of discussed. The changes that happen in menopause related to the heart, cholesterol levels go up. As we said earlier, insulin sensitivity goes down. Another way of saying that is insulin resistance goes up. Rates of type 2 diabetes increase. And then blood pressure goes up. And we talked before about BMI, obesity by BMI versus obesity by abdominal adiposity, like how much fatty tissue is around the abdomen. That, the distribution of fat around the abdomen really increases during menopause. And that's important because that's more likely to be infiltrating your organs, affecting their function, and leading to all of the, insulin resistance and metabolic problems that drive all of those bad things, whether they're heart disease risk factors or actual heart disease. So I think just having that awareness is important, because patients can drive the conversation too, right? Like the doctor, it doesn't have to be a doctor there with their like checklist, like, let's talk about your blood pressure, let's talk about your cholesterol. The reality is most doctors are overwhelmed and time crunched, and they forget to cover these bases. So if a patient who's in perimenopausal is like worried about her heart health, then she can make sure to just say, hey, has my cholesterol been checked recently? I'm curious what it is. Or, hey, what was my blood pressure today, in case you didn't catch the number when the medical assistant was doing it? Or, hey, has my hemoglobin A1C been checked recently? Because, the guidelines are the guidelines, but they're not always implemented, and may have been 10 years before since you've had an A1C done. So I think the awareness, having a little bit of self-advocacy in the room and just like asking, making sure these things are being checked and watched are probably the biggest things. Yeah. Sometimes women in menopause, either because they're having symptoms like the hot flashes or, dryness, may look into hormonal replacement therapy. And there they may run into doctors saying, ooh, it might be bad for your heart. It might make you die. It might increase the clotting risk and all this stuff. And we do know that, estrogen increases the risk of clots. But a lot of this data on hormone replacement therapy in the menopausal woman is old, and subsequent analyses have identified some flaws in the sort of headline association that hormone replacement therapy increases cardiovascular risk. We have since learned that the timing of hormone replacement therapy may matter, and that the earlier you start it, like the more proactive you are, the less likely it may be to cause downstream effects on your heart and cardiac events. So that's sort of, again, just add that to the list of just self-advocacy questions you can ask. And if you feel like your primary care doctor, who like frankly isn't trained to be like a menopause doctor, does, if you're getting the sense like, oh, maybe they don't know, or maybe they don't feel comfortable, it's fair to just ask for a referral to someone who may specialize in this. So, awareness, proactive communication with doctors. And then I think like, to my fitties here, and for all the other like aspiring, movement enthusiasts, whether it's a walk around the block or just like getting after the strength and resistance training, right? Exercise is one of the most powerful kind of like all around, checks all the boxes, treatments and preventative agents for your heart health for the perimenopausal woman. It helps maintain your weight. It's not a great weight loss vehicle, as so many know from struggling for years with weight loss, right? And trying everything, but it is a really, really effective weight maintenance tool or prevention of weight gain tool. So it's great for that. Lowers our blood pressure. It improves our insulin sensitivity with literally just one session of power walking. Your insulin sensitivity goes through the roof, and it lasts for 48 hours, like no meds needed. And obviously it is a mood elevator, like so much of menopause can really crush you psychologically. Whether you're like worried that it's coming on, or you're in it and you're dealing with all of the symptoms, or it's behind you and you feel like this sort of like life stage and chapter is closed, and there can be a little bit of depression that comes with that, kind of like the cardio depression we were talking about before, aging, etc. So I think exercise, and nothing serious, like not like my, I did a marathon, but it doesn't have to be like that. It's just walking, like literally walking, 20 minutes a day.
Like,
that's it.
What about like cleaning? It's my new thing, right? Like I hate to clean, but I
hate to clean too.
Right. And there's something, I think, because I like live on the internet with all these things, like now there's something very cathartic for me to just clean the crap out of things. Like I know it's ridiculous, but I hated it until now. Like I'm gonna go in the kitchen, I'm gonna sweep, mop the floor, I'm gonna do the dishes. Before I know it, like 20 minutes have gone by and I've just been moving like this.
And you've been moving, which is great. I mean, that counts. That counts. I mean, the other things I tell people, like I have this one patient, she's like in her 70s, and she doesn't have equipment in the home. She's like not going to go and join, Planet Fitness or anything like that. But she does have a flight of stairs in her home, and she goes up and down, like outside of her normal like chores in the house. She'll just go up and down those stairs for 30 straight minutes, gets her heart rate up, and that's it. She hasn't lost time commuting anywhere, no special equipment, didn't cost her a dime. So I think there's a lot of creative ways to work it in. I recognize it's usually part of a lot of baggage and trauma, right? So each woman needs to come to this on her own terms and find a way to make it sustainable and joyful, and to sort of, I think that like being a little bit open and curious about things that maybe you don't feel as loaded as your history, what's been in your history. So some women I've talked to, like they were doing the gym twice a day, 60 minutes at a time, hitting the elliptical, and they like the elliptical causes PTSD, but like give them a strength workout and they're all about it. Right. So I think every woman has to find the right thing for her, but as long as it's sort of hitting that level of like brisk walking or more, and you're doing 20 minutes a day of it, you are doing your cardiovascular system a huge favor as the hormone level tsunami takes over in that menopausal phase.
Awesome.
I have an anecdote.
Before Kat goes, I got one question. We have had people on that you'll like it. We have had people on the show that are going through menopause or about gone through menopause, something like that, who take GLP1s. And they were not, in appearance, obese. Okay. And I'm wondering, because you mentioned that like insulin resistance, I think you said increased was the words that you used, when you hit menopause, right?
Yes.
So does that mean that metabolically, like, I mean, it seems like sometimes like people may use this to get over that hump, to get back to where they wanted to be. It seems like some people may be maybe they've become like obese, but it's interesting because we've had other doctors on the show that one in particular, Dr. Ali, said there are people walking around everywhere right now who will never qualify for these medications, but because we know that so much of your weight is genetic, like, and they have obesity.
Right.
They have it, right? Like, They have it. They're better at white knuckling. Their BMI doesn't meet what we think it should meet, but they'll never qualify because
Right.
of it. And so,
This
like, I think
is,
that's why we have to stop, like, looking at people and
yes.
deciding if they're worthy of these medicines.
Yes, the BMI is, you know, it captures a lot, but not everything. And I think, you know, this persona that you are sketching out, I mean, it is best described. I think the group that falls most into this category is like my people, right? Like I'm half Chinese. Asians have a much higher rate of like metabolic dysregulation at a normal BMI. So they may have a totally normal BMI and look thin. They might even look skinny, like a lot of young Asian women tend to, but actually have like a high percentage of their body composition be adipose tissue with all the problems that come with that. And so unless they are actually type 2 diabetics, you're right, they're not going to meet clinical eligibility criteria and get covered by insurance for treatment with these medications, which is really tough, really tough. But yes, I think that, you know, the more we learn, the more research that's done, the better our understanding will do. And it's not that the whole healthcare system is going to be moving at the same pace with the awareness, understanding, and sort of progress. But, you know, slowly but surely, I think we will get there and things will get better. And, you know, I think we see it excitingly in heart health, where there's an appetite to do studies that will change the narrative and change like what's getting covered for what. But I think we'll see it beyond heart disease too, some of these other areas that we've talked about.
That's great.
Go ahead, Kat, sorry.
Okay. I was going to say before that about stairs. It's so funny because I have to add it. Betty White said that she did that. She didn't work out. She didn't walk, but she went up and down her stairs. Bless her.
Amazing.
I love Betty White.
If Betty White did it, you know, sign me up.
Right.
So she said that's how she kept in shape. So,
Love it.
But we got a listener question for you from Jennifer Cloth. She is on TikTok. She asks, I've suffered from a low resting heart rate, low blood pressure, and throw PVCs. And I'm going to have you explain that to us later. But it does mean extra beats. I realized that I haven't thrown PVCs in a long time. Could this be from taking a GLP-1? And also for the audience and the hosts, what is throwing PVCs and what are some of the causes, if there are any?
Yes, great question. So PVC stands for premature ventricular contraction. It's an early beat that is coming from the workhorse part of the heart, the ventricle. And it is so common. I mean, I honestly think if everyone wore a monitor or an Apple Watch or something, like it's very, very common. It can be from a number of reasons. Some of them are like scary. Some of them are totally benign. So, you know, like some people, like during exercise recovery, it's very common to just throw PVCs as you're sort of, as your body is kind of just going from being really revved up to really relaxed. But it can also it can happen when your electrolytes are out of whack, for lack of a better term. If you have low potassium or low magnesium, this can happen. If you're dehydrated, if you're really like stressed or inflamed. And then of course, if you've had a heart attack, you've had some kind of scar to your heart, whether it's a heart attack or some other issue, inflammation of the heart, that can serve as like a little nidus for extra beat, like the electrical wiring to get disrupted and for extra beats to come up. Most of the time, as I said, people aren't necessarily aware of them, but after a PVC, what happens is the heart, it's like a hiccup, and the heart often like takes a moment, takes a beat to reset and resume its natural metronome and natural rhythm. And when that pause happens, as it's sort of like resetting, that gives the heart more time to fill. And with the more time to fill with blood, the more blood it's going to be filled with. And so that next beat that comes after the hiccup or the post PVC, it tends to be more vigorous. So some people, if they feel anything, will feel that beat after the early beat. You know, and so in the case of the listener who said she has a low resting heart rate, low blood pressure, and PVCs, but less PVCs while on GLP-1s. Wasn't sure from the way the question was worded if the heart rate and blood pressure changes have come they're low now that she's on a GLP-1. I think that, you know, blood pressure, we know it can get lower on GLP-1s because, again, they relax the endothelium, that inner lining of your blood vessels, and they help us get rid of salt from our body and make our kidneys work better. Low resting heart rate, I mean, it depends on how low. But as we said before, usually it's increasing the resting heart rate a smidge. If someone had a reduction in their heart rate, I might wonder if it was because of improvement in inflammation, right? I mean, like when you're inflamed, your body's revved up and your heart rate might be going a little faster. Also, with more weight loss, your heart doesn't have to work as hard to circulate blood. So that's another reason that your heart rate might get lower without it being a problem. And then finally, again, with less inflammation and less just systemic stress to your whole body system, you know, it might just create a more hospitable and favorable environment where you're not as likely to have those PVCs. So I wonder if the case of the listener actually pulls together a lot of what we've talked about on the show tonight about how these medications are working and the myriad ways that they actually benefit the heart and protect the heart. So kind of a cool little case study there. Awesome. But if anyone is worried about that, I would just say there are lots of ways to monitor yourself, and you can always just talk to your doctor about whether you can do a monitor of some kind.
Awesome.
Very cool.
I have the last question of the night, and it's the most important question.
Yes.
When you run, what podcast do you listen to?
Obviously the plus side.
You got a few hours, you might as well. Oh,
Heartbreak Hill.
Heartbreak
Hill, ladies. I wouldn't have been up it wouldn't have made it to the top without you all. So we could say that we all ran the Boston Marathon yesterday.
We could say that. I like that.
Was it yesterday on a Monday?
I ran it.
Marathon Monday. Marathon. It's a holiday here in
I
Boston.
went with a doctor.
I do think, I'm going to just put it out there. I do think that a community athletic endeavor of some kind could be great.
So fun.
A 5K.
You too. You're in charge. Go make it.
I don't run anymore.
Make it number 2 and number 3.
A walk.
I'm a cyclist now. I do all the spin classes in the land, but
or you could do spin. You could rent out the.
You could get in a do a class with. We could do a whole plus
spin. That'd be some good
GLP1 spinning. Oh my gosh, that would be amazing. That would be amazing.
Yeah, I will say this: when I got lower on my weight before, I started the Couch to 5K app, and it taught me to run, and I was able to run 5Ks. I planned myself a 5K every month, and it was
wow.
You couldn't get me to run even if there was chocolate down the hallway before. But to go from not running to being able to run, there is that endorphin rush that it gives you.
Oh, I know. It's like a drug.
Like Kat, you do your spinning, and I think everybody just has to find that endorphin piece. And like Sabrina, I know you hate the stairs, but you're always on them, right? You do them. You do.
Love, hate.
Yeah.
That's amazing.
Dr. Lee, how long was your marathon, or how long was your run?
3 hours, 26 minutes, and 12 painful seconds at the end.
That is amazing.
But I got to see my little 4-year-old. He was there cheering me on with his little cowbell. And I mean, I think after the bombing the spirit of the city, it just feels like on the heels of the eclipse, it's like one of those moments where like humanity is coming together and we're all on the same side. And it just, you get a rush out of that. So it was fun. It
only when those things happen, it only lasts for like a few minutes. But when it does, like you got to drink it in, I think.
Oh yeah. No, it was great.
And after that, humanity comes right back around again.
It's waiting.
While we're all joined together. You know what I mean? Like during COVID, we would clap for the nurses and shit. You remember those days?
Yeah.
But then, like before we know, everybody's like trashing everybody again. So
talking about putting bleach in your veins.
Yeah, right. Yeah. Like, come on. Yeah.
But no, I mean, I think it would be fun. I mean, like a community spin or a virtual walk or something, some kind of little challenge.
Virtual walk might be,
I could do something. Cool. I don't know how quick you could put it together, but you could do something the weekend that we're doing.
Kim's kettlebelling
Like
or
the
clean your kitchen for your life.
clean
Oh,
your kitchen for your life.
Listen, I get sweaty when I clean the whole house. I get sweaty and
Oh,
crummy.
I'm telling
mean,
you, and then afterwards, and the whole time I'm doing it, I'm like, my brain will go look at your phone, go look at your phone. And I'll go, no, phone, I'm not doing it. I'm not doing it. There's
I
something
mean,
about it that really helps me. And then at the end, I'm like,
I know.
you
It's
know?
amazing. It's amazing.
Yeah.
And like my family gets so mad at me. They say that I'm punish bustling them. Like I'm like punishing them by like cleaning up the mess that they made, you know? Like they made the mess and I come in like a tornado cleaning it.
Yeah.
But no, but it's for me. It's for me.
Yeah. I mean, don't get me wrong, like I don't like to clean. Like just,
I love it.
like, ugh,
Yeah, I do it.
but I love the
Catharsis
way
though.
I love the process. But I never was like that before. Everything is different now. The way that my brain works, everything is different now.
And
You
it's
know?
just physically, it's less to take on, right? I mean,
Yeah,
it's
and also
just,
it's not like miserable, right? It's
yeah.
you can I think just I've just sort of learned like there are some like physical tasks in this world to help you ground your body, right? And like I think a lot of that is like what Kat and what Sabrina will talk about around like exercise and stuff. Like my sister's really into yoga and she's the same way. She's like, I feel grounded. I feel grounded. And with all the things that I do, where I'm always like up here and in the digital space, like it's good. It's just nice to have something.
Yeah.
I think it's like every human is
Mhm.
different. Right? Like you said, everybody's got to come to their own thing. And like me, like first diet since I was 8, right? So like that's my life. So it's always been like quit the gym, start the gym, do the thing.
Yeah.
Richard
There's a lot
Simmons.
of trauma
I've done
connected
all of it.
to
I've done
yeah.
all of it. So I just had to find something that
That
I
felt
could do
good
that
on
would
your own
equal.
terms. On
Yes.
your own terms.
Yeah.
Absolutely.
Yeah.
And there's a lot of trauma. People have a lot of trauma connected to exercise. Just
Yeah.
Oh,
I do.
Yeah.
Yeah.
a lot. I mean, we talked about dance before. My God. I
Mhm.
mean, yeah, it's everyone and everyone has their own story. And so I think
For sure.
it's totally unfair to be prescriptive or like,
Yeah.
go exercise as opposed to just learning who is
Yeah.
this person, what have they been through, what has caused trauma, what haven't they tried, but
Yeah.
might be curious about, right? And everyone's different. So
For sure. Exactly. I think and that's why like I remember when I was trying to think like what is my mantra here like on TikTok, right? It was sort of like look, like I focus on nutrition. That's my first thing. Like is there flexibility in that when I want to have like cake or something? Yeah. But it is for other people that are metabolically healthy, so why can't it be for me, right?
right.
And then movement, right? Because I'm never going to be a diet and exercise person. I'm always going to be like focus surrounding nutrition and
Yeah.
move your body. You know what I
Yeah.
mean? And then community.
Right.
So I think those are like how I've done what I've done, and if I do more in the future, but even just maintaining it, because like I don't think people realize when you're doing this, they're like, oh, lifestyle changes and trash like that. Like I don't mean like that. I mean like, how they mean it. How
Yeah.
they say
Yeah.
it. But while you're doing this, especially over a year and a half of me doing this now, my life changed, right?
Mhm.
So therefore my lifestyle changed, right? And it is I think about it constantly, but not in a negative way. Like before I had thought about it in like a constant failure way, right? Like no matter what I did, I'd constantly go gain it back and fail, fail, fail. And now it's just like, I'm just moving forward.
Yes.
It's
Yes.
just what my lifestyle looks like now. Right. And I think that I found a lot of people don't realize until they're there that they've
Right.
changed their lifestyle, because most of us never got that far.
Right. Right. No, but it kind of creates the cognitive space for you to
Yeah.
be able to take that challenge on,
Yeah.
without that sense of guilt or failure or whatever,
Yeah.
and I think
Right.
so. I think sequencing this all doesn't have to all change at once, right? Like you don't have to like transform every part of you and
Right.
every potential part of your life in like the first 4 weeks of starting a GLP-1, right? You can just focus maybe on like letting your body get used to the medication and navigating some early side effects, and then maybe like getting into some kind of healthy routine or some kind of routine that works for you on, injection routine and tracking your weight. Like some people want to see it all the time and some people don't. And then, after weeks and months, like maybe you have the space in your heart, in your mind, in your spirit to take on some of the other things. But it's a
Totally
process.
agree. Yeah, I totally agree. And we said that a lot in our lives, right? And where people like, I've only lost a pound. I've only lost 10 pounds in a month. I've only like my first month. And, just stuff like that. And I'm like, like the managing expectations and the level of misunderstanding and misinformation, even just getting this from like a GP or wherever is vast. And so like, I do want people, like, I think it's the first time ever in my life I've done it right. And what I mean by that is I didn't do those things you just mentioned. I didn't rush into it and go, I got to go to the gym. I got to buy the workout gear.
Right.
Commitment. This is what commitment looks like. Right. And that's what I told myself, right, is this means that I am going to do it. No, it doesn't. So what I did is I just said, maybe a little less.
Right.
You know? That's it. And I just sort of like
small sustainable changes.
And then when I started to feel a little better, I was like, I'm gonna move a little more. You know what my goal is? My goal is to keep up with my laundry, to keep up with my dishes. That's it. Not let them pile up. That's it. That's my goal.
Good goal.
You know?
Yeah.
That's and that process allowed the lifestyle thing to happen. You know?
Right.
So everybody's different. Like some people, but I just didn't want a diet culture because that doesn't work for me.
Right. And for so many.
A million times. I mean, every year I'm at this, you know? So this is a whole new way of doing things. It can get exhausting, like to be like, but I feel like people that are trying to live a healthy lifestyle gets exhausted for them too.
Mm-hmm.
You know, like they feel that way too. Like, I mean, don't you sometimes be like, I don't want to run again? Like,
yeah,
you know,
no, it's true.
you know?
It's true. There are
like,
days I
no matter how much you like it, there are days you're like, you know, and I know.
How long of a break do you have to take after running your marathon, Dr. Lee?
I think
like
it'll
a
be
week?
like, I mean, this week I'll just be focusing on walking.
I just want to roll out of bed. That's it.
Right?
I know. There's this social media app called Strava for like, you know, runners and cyclists and stuff. And I joked today, I was like, I feel like I should post there that like I successfully got out of bed. Like that was the victory of the day. But yeah, I mean, this week it'll be very low key. And then over the coming weeks, some jogging, you know.
You could also just be like, and I was also on a podcast where I educated thousands.
Yes, I moved my mouth.
Yeah.
I moved my mouth. Doesn't that count?
That was movement.
This was so fun. This was a joy.
Yeah.
Well, thank
Dr.
you
Lee,
so
can I
much.
ask you a real quick question?
Of course, of course.
So one of the things that surprised me when I started having the symptoms of what was going on is the pain was right here, more in the sternum. And we all watch TV shows and all of that. You see them go, oh, my arm. Usually have a heart attack. And that is something that my immediate thought was not heart attack.
Right. No, this is very important.
Can you describe the different ways these symptoms can manifest in people so that way if people are having those feelings that they can seek the help that they need? Because like I said, not everybody lives across the street from a hospital. I was very lucky.
Yes. No, that's a great question. And it's one that like we try to bring up during Heart Awareness Month, which is February every year. All of the descriptions of heart attack symptoms, like an elephant sitting on my chest and some jaw pain or arm pain, these symptoms or this description emerges from studies done, you know, in shocker, Caucasian men. And so like, you know, everyone is stunned to learn that the people who are not Caucasian men don't necessarily experience heart attacks the exact same way. And so, you know, whether it's diabetics who may not experience anything at all, that's, you know, we call that a silent heart attack, or women or just people who have non-Caucasian backgrounds, they can have a whole, you know, spectrum of manifestations of what actually are heart attacks. And so, you know, in women, it could be what you experience, just some like central pain. It could be shortness of breath. You know, I don't say this to alarm anyone, but I think when it's sudden, when it's severe, and it's like very intense, you know, definitely pay attention. But yeah, shortness of breath, just fatigue, indigestion, you know, heartburn type of things. These are all very common fake outs or just like, you know, symptoms that people end up being dismissed when people go to seek medical attention, but that should be taken seriously if someone is set up with all the risk factors and they've experienced a sudden intense change. So, you know, it was so great that you went right across the street and you didn't try to wait it out. Because obviously the sooner that we say time is heart, you know, or time is brain if it's a stroke. And the sooner you get medical attention and restore the blood flow, the better one does in the long term.
Thank you for that.
Of course.
Such a good way to end it. Thank you so much. Great
Oh,
question, Matt.
Yes.
Yes, great
Awesome.
question. And
Hopefully
great,
this helps somebody, you know?
yes, no, great time with you guys. Such a fan of all the work you're doing. It's so important. And to be a small part of it, really,
Absolutely.
yeah, such an honor for me.
And let's
Please.
change things. Let's get loud and change things. Okay?
Wear your 80s clothes.
Right. All right. We'll go ahead and say goodbye to our listening and viewing audience, and we will see you guys next week. Hasta la
Bye.
pasta.
Bye.
Bye.